Welcome to the session of abortions. This is a very clinically important entity which we see in clinical practice, as well as this topic is very important from your exam point of view. So let's study abortions today. We'll divide this topic on the following division, that is definition, what exactly abortion means, what are the types, what is the etiology, what are the common causes depending on the period of gestation of the abortion, what is the management, what are the likely complications, and what post-abortal care we should be giving to our patients. By definition, abortion means termination of pregnancy, maybe expulsion or extraction before the period of viability or when the fetus is less than 500 grams. Now this definition has changed over a period of time as the period of viability has changed, because initially it was considered as 28 weeks. The fetus becomes independently viable once it comes outside the uterine cavity. But now, because of improved NICU care, the definition has almost shifted to 20 weeks. 20 weeks and onwards the fetus becomes viable. Before that it is considered as non-viable fetus, and thus it is included in the definition of abortion. Abortion can be spontaneous or it can be induced. Now we are going to focus on spontaneous abortions, where the patient is willing to continue the pregnancy, but because of some clinical condition, diseases, disorders, she is unable to continue the pregnancy and the pregnancy gets spontaneously aborted. The incidence of this condition is almost 10 to 20% in all the clinical pregnancies, and out of which almost 80% occur in first trimester, out of which 50 to 75% abortions are because of chromosomal abnormalities. Spontaneous abortion can be of two varieties, either isolated or recurrent. One single abortion, or maybe getting repeated in next pregnancy, and likewise. Or it can be an induced abortion, legal or illegal. This we are not going to deal right now. We are just going to concentrate on spontaneous abortions. What are the types of spontaneous abortion? Threatened abortion, inevitable, incomplete, complete, and missed. These are all types of spontaneous abortions. Abortion, a patient coming to us can be at any of these conditions. We have to diagnose it and treat it accordingly. Management of all these conditions vary from type to type, and we'll be seeing all these types in detail. Again, I want to highlight here that the incidence of spontaneous abortion in general population is almost 10 to 20%, and most common cause of first trimester abortion is either the defect in embryo or it can be called as chromosomal abnormality. This is a very important question asked most frequently, that what is the most common cause of first trimester abortion. Please remember guys that it is chromosomal abnormalities found in the embryo, or in other words we can call it as defect in an embryo. Now we are seeing the different causes. First one is genetic. Usually, genetic is the cause in first trimester abortions. You all know first and second trimester. First trimester is till 12 weeks. Second trimester is then onwards, almost from 12 weeks to 20 weeks. So the causes are again divided. Most common causes in first trimester, most common causes in second trimester. We are seeing the causes in general. Genetic is the cause, but it is more commonly found in first trimester abortions. We may call it as blighted ova. Blighted ova is a clinical entity again. On ultrasound, you will find that the gestational sac is seen there, but you will not be able to see a fetal pole and fetal cardiac activity in that particular sac, and that is called as blighted ovum. Usually these type of abortions are less than 8 weeks, and genetic cause is most common. Out of these genetic causes, a question can come this way, that which is the most common genetic abnormality which is seen in first trimester abortion. Now these abnormalities they can be trisomies. You all understand trisomy means presence of one extra chromosome. It may be anything from 1 to 23 chromosomes, any chromosome can be extra. Except one, all the trisomies can get aborted. But which is the most common trisomy which gets aborted? And that is trisomy 16. Again, very important point. Many times this has been asked. Other trisomies are 13, 18, 21, 22 and likewise. Other abnormalities can be polyploidy. In polyploidy, a complete set of extra chromosome is added. That means if it is triploidy, then the chromosomal number would be 69. If it is tetraploidy, 92 and likewise. Monosomy. Over here one chromosome is absent and the most common 45X. Other abnormalities can be translocations where the chromosomes are present but the genes are translocated. There can be deletions, inversions, and almost in 4% of these causes of genetic abnormalities, these varieties are seen. Moving ahead to the other important cause of first trimester abortion. Again, remember guys, after genetic abnormalities, endocrine, that means hormonal abnormalities, is the second most common cause of first trimester abortion. So if your MCQs doesn't have genetic abnormalities, you have to go for this cause as the most common cause. This is the second most common cause for first trimester spontaneous abortion. Now what are these? They can be luteal phase defect, thyroid abnormalities, and diabetes mellitus. As you all understand, luteal phase defect is where progesterone is deficient. It's not present in the body as per the requirement. So the decidua where the implantation takes place is not in congruence with the pregnancy. And this deficiency of progesterone leads to defective decidua formation and thus defective implantation, and the pregnancy cannot go ahead and it's get terminated, that is abortion. Thyroid abnormalities, both hypo and hyperthyroidism, both can cause abortions. Diabetes mellitus, especially if it is uncontrolled and or poorly controlled, can lead to abortion. So if you have a patient, we should take history or investigate her to rule out these abnormalities which are metabolic as well as hormonal. Anatomical causes. As you can see on the board, in second trimester abortion I have written uterine anomalies, that means anatomical causes. So this cause is more important from second trimester point of view. In second trimester, these are the most common causes which will lead to abortion. And the causes are cervical incompetence or congenital malformation of the uterus. Now what malformations? Common are like bicornuate uterus, septate uterus, unicornuate uterus. These are the abnormalities seen in the uterus which will lead to abortions, usually either late first trimester or in second trimester. Now what are the reasons? The uterine cavity is smaller, it cannot get distended, the decidua is defective, vascularity is affected, implantation is defective, and naturally after a certain gestational period the pregnancy cannot get carried forward. Uterine fibroids. Depending on the size of the fibroid and the location of the fibroid, it causes abortion. If the fibroid is bigger and more towards the cavity, that means the submucous variety, it's more likely to affect the pregnancy, and abortions are quite commonly seen in these type of uterine fibroids. Intrauterine adhesions, synechia formation. You all remember, once I say intrauterine adhesion, Asherman syndrome has to come to your mind. Asherman syndrome, over there are intrauterine adhesions, and these adhesions again lead to defective decidua formation. The decidua is not at all receptive, the vascularity is not good, placental implantation is defective, and thus it leads to abortions. Cervical incompetence, most common cause, where we are going to see this cause in detail, so I did not stress it, but just to explain that the cervix is incompetent. It cannot hold the pregnancy for a longer period, the internal os opens up and pregnancy gets terminated. To stress the point that this is again it's the most common cause of second trimester spontaneous abortion. Going towards the next cause, infections. These infections will again lead to second trimester abortion than first trimester. And the infections are viral infections, parasitic and bacterial. Viral in the form of rubella, cytomegalo, varicella. Parasitic, you all know torch group, toxoplasma, malaria. Bacterial, ureaplasma and chlamydia. These are the bacterial infections which will lead to abortions. Again, a bigger and important chunk of immunological causes which leads to spontaneous abortions. What happens? Our body have antigens and antibodies are formed against our own antigens. They can be anti-nuclear antibodies, there can be anti-DNA or anti-phospholipid antibodies. And which are the two most important anti-phospholipid antibodies? One is lupus anticoagulant and the other one is anti-cardiolipin antibodies. Over here, antibodies are formed against these antigens, which leads to thrombus formation, more commonly in venous. That leads to placental thrombosis. Naturally, placental thrombosis affects the vascularity, thus leading to infarction or ischemia, and thus that will lead to fetal hypoxia. Now, depending on the severity of this fetal hypoxia, we might have intrauterine death or just IUGR or abortion or other symptoms like pregnancy-induced hypertension or abruption can be seen. Now, alloimmune is where antibodies are formed against the paternal antigen. This is another cause of abortion. And one more other cause, which is immunological again, is inherited thrombophilias, where most commonly protein C resistant is seen. Protein C is a substance which avoids formation of thrombus in the intravascular system. When there is resistance to this, there is again initiation of thrombus formation, which will have consequences as we have discussed, that is placental thrombosis, infarction and fetal hypoxia. Then there is this miscellaneous variety in which maternal medical illnesses like cyanotic heart disease, hemoglobinopathies, again very important, blood group incompatibility, that is Rh negative mothers, premature rupture of membrane, smoking and alcohol seen in the mother, sperm chromosomal abnormalities and unexplained causes will also lead to spontaneous abortions. Now again I am stressing on this point. Common causes divided according to the first trimester and second trimester causes. Genetic, most commonly seen in first trimester. Endocrine, second common. Then trauma, maternal medical illnesses, inherited thrombophilias, alcohol, caffeine and unexplained. In second trimester, most common is anatomical, uterine anomalies, then immunological, Rh isoimmunization, maternal infections, maternal medical illnesses and unexplained. Now let's see what are the types and how to diagnose them and treat them. Threatened abortion. It's a clinical entity where the process of miscarriage or abortion has just started but has not progressed to a state from where the recovery is impossible. Means if you diagnose this condition and treat it, the pregnancy can still be continued. The patient usually presents with slight PV bleeding, usually painless. If you examine her, the uterus corresponds to the gestational age. Means all the product of conception are inside the uterus. The size of the uterus is according to the gestational age. And you will find that the cervix is closed. Minimal bleeding can be seen. Do the routine investigation which we do in antenatal cases. Ultrasound gives us information. How is the pregnancy? What is the gestational age? Fetal heart present, absent. How is the decidual reaction? That confirms the diagnosis that this is just a threatened abortion. And treat the patient with rest, analgesics. Ask her not to have strenuous activities, even avoid sexual intercourse. Role of progesterone. Clinically, we usually give natural progesterone to these patients, but it is still debatable. Progesterone can be given if it is included in your multiple choices. Inevitable abortion. This is a clinical type which is little ahead of threatened abortion. Over here, the change has progressed to a state from where continuation of pregnancy is impossible. Means the patient would have more bleeding, she would have pain, cramps, heavy PV bleeding, and on examination you will find the uterus is tender, which corresponds with the gestational age, but over here the difference is cervix would be dilated. Pregnancy is trying to come out. Product of conception may be felt which are coming out through the cervical os. So in this condition, continuation of the pregnancy with our medical or surgical management is not possible. That is why it is called as inevitable abortion. Management: if required, blood transfusion, but not very commonly required. If the gestational age is 12 weeks and less, then we can immediately do vacuum aspiration, either suction evacuation or dilatation and evacuation. Gestational age with more than 12 weeks, we can await for spontaneous expulsion. We can give oxytocin drip to augment and confirm that the abortion process is complete. If required, we can do check curettage in both the places. Incomplete abortion. Over here, as the word suggests, some of the products of conception are already expelled out, but some are still remaining inside the uterine cavity. So we call it as incomplete abortion. Patient presents with painful uterine contraction, heavy bleeding, and she usually gives history that something she has expelled out. On examination now here, the uterus would be smaller, which is natural that some products of conception are already out, so the uterine size would be smaller than the gestational age. Cervix would be dilated. Partial expulsion of products of conception would be there. We have to take precaution in this case because as products of conception are already out partially, it may lead to heavy bleeding. So depending on her general condition, we have to give her IV fluids, may require blood transfusion sometimes, but at least we should send blood for grouping and cross-matching and surgically take out whatever are the remnants which are there in the uterine cavity still. Depending on the gestational age, we will choose the procedure. Usually these patients require check curettage. Medically, we can give misoprostol 200 microgram PV every 4 hourly depend if she is non-bleeding actively. Complete abortion. As the name suggests, abortion process is complete. The products of conception has expelled out en masse. She usually presents with heavy bleeding followed by decrease in bleeding, and she gives history that some sac-like pinkish clot she has already expelled out. On examination, you will find that the uterus is smaller than the gestational age, and now here the os is closed. As in threatened abortion, the os was closed. Here also everything has come out and now the cervix is getting closed. We have to do either transvaginal sonography or transabdominal sonography to confirm that the uterine cavity is empty. Because you all know that if products of conception remain inside, they will act as a focus for bacteria and infection might set in, leading to septic abortion. So we have to do ultrasound to confirm that nothing is there in the uterine cavity and the cavity is completely empty. If not, then we have to do check curettage and make the cavity empty. If the patient is Rh negative, in all abortions, it's better to give her anti-D within 72 hours to avoid the isoimmunization. Missed abortion. When the fetus is dead inside the uterus, but still retained in the uterine cavity for a variable period of time, we call it as missed abortion. Clinical presentation can be persistent dark color bleeding, or maybe there is subsidence of pregnancy symptoms. The growth just ceases, absent FHS depending on the gestational age. An examination reveals a firm uterus which is smaller than gestational age and the cervix is closed. Means the fetus has died inside, but still the process of expulsion has not yet started. But eventually they all will be expelled out spontaneously. Over here we can try both the methods, either medical or surgical. Medically we can use drugs like misoprostol, or surgically either MVA or suction evacuation and dilatation and evacuation. It's important to check bleeding in diastasis in these cases because if the missed abortion is for longer time, it may lead to DIC, that is disseminated intravascular coagulation. So before doing any procedure on this patient, we have to always check for the bleed in diastasis like bleeding time, clotting time, prothrombin time, and confirm that the patient is not in DIC. In missed abortion, there are two more terminologies which I would like to include over here. One is carneous mole or incarcerated pregnancy. In this condition, as the fetus is dead for a longer time, the fluid around the fetus gets absorbed by the body, and then this dead fetus gets shifted or it converts into mole. It's a variety of missed abortion only, which is there for a longer period of time, and the treatment is also same. But you have to remember these names, that it may be called as carneous mole. Septic abortion. Any abortion associated with clinical evidence of infection of the uterus and the contents of it, it is called as septic abortion. It is usually seen in unsafe abortions, induced, illegally done, or the mode of abortion were not proper, or maybe somewhere incomplete abortion and patient has not reported to the hospital, and the proper treatment was not given, or the cavity was not cleaned, prolonged retention of products of conception, or incomplete or unsterile evacuation of the uterus, even though the procedure was done in legal place properly, but it was incompletely evacuated. As you know that this remnants, the products of conception, they act as a very good source for bacterial growth, and then the infection sets in, and which leads to septic abortion. Clinical features can be fever, abdominal pain, foul-smelling PV discharge, and PV bleeding. The signs would be, depending on the condition, there can be tachycardia, abdominal tenderness with boggy feel of the uterus. Patient may come in shock if it is the procedure has set in. Confusion, hypothermia, oliguria can be the symptoms. Now there are grades depending on where the infection is. Grade 1, if the infection is localized in the uterus. Grade 2, if the infection spreads beyond uterus, that is to the parametria, tubes, ovary, or pelvic peritoneum. And grade 3, there is generalized peritonitis, or maybe endotoxic shock, or acute renal failure, or jaundice. Then we call it as grade 3 septic abortion. This can be a cause of maternal death, so we have to be very cautious when we are treating septic abortion. Management, we need to do investigations like hemogram, blood group and cross match, urine analysis along with culture. We should send cervical or high vaginal swab to know which kind of bacterial infection or any other infection we are dealing with. Depending on the growth, we will be in better position to select the proper antibiotics for our patient. Ultrasound to detect what is the size of the uterus, what are the contents, whether there is any pelvic abscesses formed. So ultrasound will guide us what is the spread of the abortion or septic abortion. Blood culture, again very important investigation to know what kind of antibiotics we need to choose. Serum electrolytes, coagulation profile, because DIC is very common in this condition. Treatment, always hospitalize the patient. IV fluids depending on the degree of shock, and always start the treatment with broad spectrum antibiotics which will cover the whole spectrum till the reports of cervical culture, urine culture or blood culture are available. She should be under the cover of broad spectrum antibiotics. Anti-tetanus serum should be given, gas gangrene if required. Now, we all understand that till we evacuate the cavity, patient is not going to respond. So evacuation becomes very important. It's done at convenient time within 24 hours in grade 1 with the antibiotic coverage. Give her IV antibiotics and within 24 hours or after a course of antibiotic, then take her for evacuation. Do the required procedure like dilatation and evacuation or suction evacuation, check curettage and complete the process of abortion. Empty the cavity. Patient will respond. Grade 2, the infection has spread to the pelvis. IV antibiotics are given for 48 hours and then evacuation is done. For the patient has the infection which is already set in should get controlled, and then we should go for a surgical procedure. That's the whole concept. But in case if the patient is coming with heavy excessive bleeding, these criteria don't apply. We have to do evacuation as early as possible under the cover of antibiotics. Grade 3, You know the presentation. So in this case, we have to first control patient's general condition. We have to give her oxygen, vasopressor if she is in shock. And then once her general condition improves and settle in, then we can go for surgical evacuation. Usually in cases of peritonitis, abscesses, we have to go for laparotomy. Now complications of abortion, immediate are like hemorrhage, injury to the uterus or other organs. You all know perforation is very common because this is a blind procedure. When we are doing abortions, we cannot see, or this is basically in cases of the evacuation procedures we do in case of incomplete or septic or missed abortion. Endotoxic shock, general peritonitis, acute renal failure, thrombophlebitis. And remote complications are like pelvic pain, dyspareunia, ectopic pregnancy, and it may lead to secondary infertility. If the check curettage is done overzealously, then there would be synechia formation. Or in case if sepsis is very common and it affects fallopian tube, it may lead to PID and affect fertility of the patient. So again, these complications are very important and questions would be asked on immediate or remote complications of abortions. Now these are few questions which I would like to highlight over here because they are a little different. Post-abortal sepsis causing renal failure is likely to be due to. So the answer is Clostridium. Dear students, please remember Clostridium is the most common cause which leads to post-abortal sepsis causing renal failure. After septic abortion, if the patient has infective endocarditis, the most commonly affected valve would be tricuspid. Rather than any other mitral, aortic and pulmonary, the most commonly affected is tricuspid. I would like you to remember these two things. After the abortion, patient needs post-abortal care. As we know that 10 to 20% of the pregnancies are going to get aborted. Such patients are in emotional as well as in physical trauma. So we have to counsel the patient. We have to give her information regarding the process, the causes. We need to evaluate her and come to a conclusion. We should plan follow-up visits with her and assess her recovery and feedback for family planning procedure if required, or for next pregnancy. We should be counseling her that in next pregnancy she will not have this accident again. We have to inculcate this confidence in her, and that is what is needed and done in the form of tender loving care, that is TLC, which is a very important part of management of abortion and post-abortal care.